Your legs are speaking a language your brain desperately needs you to understand, and for women over 60, these 10 silent signals could be the difference between prevention and catastrophe. When we consider the architecture of the human body, we often think of the brain as the command center, the heart as the engine, but we rarely pause to contemplate the legs as messengers of what is happening in the most delicate vessels of our cerebral landscape. Yet there exists a profound connection between the circulation in our lower limbs and the intricate network of arteries feeding our brain, a connection that becomes particularly eloquent in the bodies of women who have crossed the threshold of their 6th decade. The process begins not with a sudden event but with a gradual transformation that has been unfolding since the ovaries began their slow retreat from estrogen production, typically years before menopause itself announces its presence. Estrogen, we have learned, is far more than a reproductive hormone. It functions as a guardian of our vascular system, maintaining the flexibility and responsiveness of blood vessel walls, regulating inflammation at the cellular level, and influencing how our bodies manage cholesterol and clotting factors. When this hormonal protection diminishes, the entire circulatory system must adapt to a new reality. The arteries, once supple and responsive, begin to stiffen. The endothelial cells lining these vessels become less efficient at producing nitric oxide, that elegant molecule that allows blood vessels to dilate and contract as needed. The result is a vascular system that operates under different rules, with different vulnerabilities. What makes this particularly relevant to stroke risk is that the same processes affecting the arteries in our legs are simultaneously transforming the cerebral arteries. The body does not selectively age one region while preserving another. When atherosclerotic changes begin accumulating in the peripheral vessels of the legs, when small clots form more readily, when inflammation markers rise in the bloodstream, these changes are reflected throughout the entire vascular tree. The legs, however, give us something the brain cannot: visible, tangible, physically obvious signs that something in the circulation has shifted. A sudden weakness in the calf, a persistent cramping that follows an unusual pattern, a foot that feels inexplicably colder than its counterpart, these are not merely local phenomena but potential harbingers of systemic vascular compromise. The fascinating reality is that peripheral arterial changes often precede cerebrovascular events by months or even years, offering a window of opportunity that nature has built into our biology. The legs require substantial blood flow, they contain large muscle groups with significant metabolic demands, and any reduction in circulatory efficiency manifests relatively quickly as discomfort, weakness, or sensory change. The brain, by contrast, can mask early vascular insufficiency through redundant pathways and compensatory mechanisms until the moment when compensation fails and stroke occurs. Understanding this temporal relationship transforms our legs from mere instruments of locomotion into sophisticated diagnostic tools, constantly broadcasting information about the state of our vascular health if only we develop the attentiveness to listen. The body speaks in symptoms, and when it comes to vascular compromise threatening the brain, the legs often deliver the first vocabulary of warning. These signals are not random or mysterious but follow logical patterns rooted in how blood flows, how nerves transmit information, and how tissues respond when deprived of adequate oxygen and nutrients. The first sign often appears as an asymmetry that was not present before, one leg that suddenly feels weaker than the other, perhaps most noticeable when climbing stairs or rising from a seated position. This unilateral weakness suggests that blood flow or neural signaling has become compromised on one side of the body, a pattern that mirrors how strokes themselves typically affect one hemisphere of the brain and consequently one side of the body. Cramping takes on a different character when it signals vascular trouble rather than simple muscle fatigue or dehydration. These cramps arrive with unusual persistence, often affecting the calf muscles during rest or minimal activity, sometimes waking a woman from sleep with their intensity. The pain may ease with movement initially but returns with disturbing regularity, reflecting the inadequate blood supply to muscle tissue that demands oxygen. Alongside these cramps, some women notice a heaviness in the legs, a sensation of dragging or profound fatigue that seems disproportionate to their level of activity, as if the legs themselves have grown heavier overnight. Temperature becomes a revealing diagnostic clue when one foot or leg feels distinctly colder to the touch than its partner. This coolness reflects reduced blood flow to the extremity, the same circulatory insufficiency that may be affecting cerebral vessels. Some women describe a foot that feels almost numb with cold even when wearing warm socks, even in comfortable room temperatures. Related to this is a change in skin appearance, where the leg may take on a pale or bluish tint, or conversely, develop a shiny, tight quality as tissue responds to chronic inadequate circulation. Sensory disturbances manifest in various forms, from tingling that feels like pins and needles to patches of numbness that come and go without apparent cause. These paresthesias indicate that peripheral nerves are not receiving adequate oxygenated blood, a condition that parallels what may be developing in cerebral tissue. Some women report a sensation of the leg or foot falling asleep more frequently than before, or experiencing electric shock sensations that travel down the leg unpredictably. Changes in walking pattern offer another crucial signal. When a woman who previously moved with confidence finds herself shuffling slightly, losing balance more easily, or feeling uncertain about foot placement. This gait disturbance may stem from weakness, sensory loss, or the brain's struggle to coordinate movement when vascular supply wavers. Swelling that appears in one leg but not the other, particularly when accompanied by any of these other signs, raises concern for clotting issues that increase stroke risk substantially. Finally, the appearance of slow-healing wounds on the feet or legs, sores that resist normal healing timelines, points to circulation so compromised that tissue repair cannot proceed normally, a state that demands immediate medical attention. The female body navigates stroke risk through a landscape shaped by decades of hormonal influence, cardiovascular adaptation, and biological processes that diverge significantly from male physiology. To understand why women over 60 face their own distinct pathway towards cerebrovascular events requires examining not just the present state of their vascular system, but the entire journey their bodies have taken through reproductive years, pregnancy, perimenopause, and beyond. Every menstrual cycle throughout a woman's fertile years involved fluctuations in estrogen and progesterone that influence blood pressure, coagulation factors, and vascular tone. Every pregnancy placed extraordinary demands on the circulatory system, requiring a 50% increase in blood volume and profound adaptations in how vessels dilate and constrict. These experiences leave lasting imprints on cardiovascular function that persist long after reproductive capacity has ended. When menopause arrives and estrogen levels decline precipitously, the vascular system loses a protector it has relied upon for decades. Estrogen receptors exist throughout blood vessel walls, and when these receptors no longer receive their accustomed hormonal signals, the vessels themselves change character. They become less elastic, more prone to inflammation, more susceptible to the accumulation of arterial plaques. Women experience a rapid acceleration in cardiovascular risk during the years immediately following menopause, a shift so pronounced that it erases much of the protective advantage they enjoyed during their younger years compared to men. Blood pressure tends to rise, cholesterol patterns shift unfavorably, and inflammatory markers climb, creating a perfect convergence of risk factors. Beyond hormonal changes, women over 60 contend with autoimmune conditions at higher rates than men, disorders like lupus and rheumatoid arthritis that create chronic inflammation throughout the vascular system and substantially elevate stroke risk. Migraine with aura, more common in women, carries its own cerebrovascular implications that accumulate over decades. Atrial fibrillation, that irregular heart rhythm that allows blood to pool and form clots, affects women differently than men, often producing more subtle symptoms that go unrecognized longer, allowing dangerous clots to form and travel to the brain. The female body also metabolizes medications differently, processes clotting factors through distinct pathways, and responds to stress through hormonal cascades that influence blood pressure and inflammation in sex-specific ways. Women are more likely to experience what researchers call non-traditional stroke symptoms, manifestations like sudden fatigue, confusion, or generalized weakness that do not immediately signal cerebrovascular emergency to either the woman herself or to medical professionals. This diagnostic ambiguity means women sometimes receive treatment later than men, missing critical intervention windows. There exists as well a social dimension to this biological reality, as women over 60 often serve as caregivers for aging partners or relatives, prioritizing others' health needs above their own subtle symptoms. They may dismiss leg weakness as normal aging, cramping as simply doing too much, coldness as poor circulation that everyone experiences. This intersection of biological vulnerability and social conditioning creates a situation where women face elevated stroke risk through multiple converging pathways while simultaneously being less likely to recognize and act upon the warning signs their bodies provide. Sentences. 1631. We live in an age of profound disconnection from the physical self, a time when consciousness resides primarily in screens and schedules, in the endless stream of external stimuli that pulls our attention outward while the subtle communications of our own flesh go unheeded. This severance from bodily awareness represents more than mere distraction. It constitutes a fundamental loss of wisdom that our ancestors possessed by necessity, the ability to notice when something within the organism has shifted, when the normal rhythms have been disrupted, when danger announces itself through sensation before it manifests as crisis. For women over 60, reclaiming this attentiveness becomes not merely beneficial but potentially life-saving, a practice that bridges the gap between the body's early warnings and the conscious mind's capacity to act. Consider how rarely we pause to truly inhabit our physical form, to conduct what might be called an internal inventory of sensation and function. We move through days propelled by habit and obligation, noticing our bodies primarily when they produce pain loud enough to interrupt our thoughts or dysfunction dramatic enough to halt our activities. The quiet signals, the slight asymmetry in how our legs feel, the subtle change in sensation when standing, the minor alteration in our walking rhythm, these whispers from our physiology compete poorly with the demands of daily existence. Yet within these whispers lies information of profound importance, messages encoded in the language of nerve and vessel, muscle and skin. Developing bodily awareness requires a deliberate cultivation of attention, a practice as rigorous in its own way as any scientific discipline. It means creating moments throughout the day to pause and genuinely feel what is happening in the legs, to notice temperature, strength, sensation, to compare left with right, today with yesterday. This is not hypochondria or obsessive health anxiety but rather a mature relationship with the physical self, an acknowledgement that consciousness resides in flesh that ages, that changes, that sometimes fails. There exists a kind of reverence in this practice, a recognition that the body which carries us through existence deserves our attentive presence, our willingness to listen when it attempts communication. The philosophical dimension of this awareness extends beyond mere symptom detection into questions of agency and responsibility. When we ignore bodily signals, we abdicate a fundamental form of self-knowledge and self-care. When we cultivate the ability to notice subtle changes, we claim a kind of sovereignty over our own health trajectory, positioning ourselves as active participants rather than passive victims of biological processes. This attentiveness acknowledges our mortality while simultaneously asserting our right to influence how that mortality unfolds, to catch warning signs early, to intervene before catastrophe. In traditional cultures, elders were valued partly for their accumulated bodily wisdom, their ability to read the signs of illness and health in themselves and others. Modern medicine has given us extraordinary diagnostic tools and interventions, yet it cannot replace the foundational act of noticing, the individual woman's recognition that something has changed in how her body moves through space and time. This noticing represents the essential first step in the chain of events that can prevent stroke, making bodily awareness not a luxury of the worried well but a practical necessity grounded in both scientific understanding and existential wisdom. Recognition without action remains merely observation, and for women over 60 experiencing leg symptoms that might herald stroke, the translation from awareness to appropriate response can mean the difference between preserved neurological function and devastating loss. The challenge lies in distinguishing the normal accompaniments of aging from signals that demand urgent medical evaluation, a discernment that requires both knowledge and trust in one's own perceptions. Age does bring legitimate changes to the legs, a gradual reduction in muscle mass, some stiffness upon waking, occasional tiredness after exertion that takes longer to resolve than it once did. These changes typically occur symmetrically, progress slowly over months and years, and exist within a stable pattern that becomes familiar. What should capture attention and prompt action are departures from this established baseline, symptoms that appear suddenly, affect one side more than the other, or intensify rapidly over days rather than evolving gradually across seasons. When a woman notices leg weakness that prevents her from performing tasks she could accomplish yesterday, when cramping awakens her multiple nights in succession, when one foot feels markedly colder than the other, these are not signals to monitor casually over weeks but reasons to seek medical evaluation within days. The window for stroke prevention is measured not in months but in the brief span between when vascular compromise begins announcing itself and when an actual cerebrovascular event occurs. Every day of delay is a day when a clot might form, when arterial narrowing might progress to complete blockage, when the brain's blood supply teeters closer to catastrophic failure. The medical evaluation itself should be approached with clarity about what is being sought. A woman presenting with these leg symptoms is not asking for reassurance that nothing is wrong but requesting assessment of her stroke risk through appropriate diagnostic tools. This means blood pressure measurement in both arms, evaluation of peripheral pulses, listening for bruits or abnormal sounds in the carotid arteries, possibly imaging studies of the cerebral vessels, assessment of heart rhythm for atrial fibrillation, and blood tests examining clotting factors, cholesterol, and inflammatory markers. If a healthcare provider dismisses these symptoms as normal aging without conducting thorough vascular assessment, a woman has every right to request specific evaluation or seek a second opinion. Self-advocacy in this context is not aggression but appropriate insistence on receiving care calibrated to genuine risk. Time becomes the crucial variable in stroke prevention, because treatments exist that can dissolve clots, address arterial narrowing, regulate heart rhythms, and modify risk factors, but only if implemented before brain tissue dies. A transient ischemic attack, sometimes called a mini-stroke, often precedes a full stroke by hours or days, presenting as temporary weakness, numbness, or confusion that resolves spontaneously. The resolution deceives many into believing the danger has passed, when in fact the danger has simply announced its presence and promised to return with greater force. Leg symptoms that align with vascular compromise deserve the same urgency, the same immediate attention, because they represent the body's desperate attempt to communicate that the circulatory system has entered a state of precarious dysfunction requiring intervention before irreversible damage occurs in the brain.